The MonumenTAL-1 study is really exciting, and I should start with we're very excited to mention that the phase 1 portion of the study just got published in the New England Journal. And to distinguish that a little bit from what was being presented at ASH, MonumenTAL-1 phase 1 that was in the New England describes the phase 1 study results of the bispecific antibody known as talquetamab. And this bispecific binds CD3 and a target on myeloma called GPRC5D. And in the phase 1 study, which was dose escalation of a variety of doses, both IV and sub-Q formulations, we saw a response rate around 70% and kind of certain predictable side effects. And so here at ASH, the purpose was to validate those studies in a phase 2 study. And so that's really what was presented for the first time here at this year's ASH, is these patients who got the 2 recommended phase 2 doses. So the mechanism of action of a bispecific is to basically traffic the T cells to the cancer. And what's important about this is because you need to pick a target that's ideally uniquely expressed on myeloma, but spares the other body parts. So GPRC5D is heavily expressed on myeloma, almost universally, less so on normal plasma cells, and even less so in the normal hematopoietic stem cell compartment, which is important for the adverse event profile. It is also expressed in heavily keratinized tissue like skin and nails. So we do see that as part of the adverse event profile. But basically, by having this bispecific bind to these 2 particular targets, you get the specificity of having your immune system target the cancer and ideally minimize off-target toxicity. So to put the findings of this study into context, I want to briefly mention who these patients were, because I think the remarkable outcomes really are in the context of who got enrolled. So there were 60% of these patients were high risk in some fashion or another, and that includes in the modern era of T-cell redirection. So ISS3, extramedullary disease, and also high-risk patients. So these were high-risk patients. They typically received a median of 5 to 6 lines of therapy over 5 to 6 years. And a lot of these patients were triple-class exposed and refractory as well. About 3/4 were triple-class refractory and 1/4 were pentadrug refractory. And almost every patient, about 95%, were progressing on the last line of therapy. So with this heavily treated population, we saw a response rate of 73 to 74% at 2 important cohorts, 0.4 milligrams per kilogram every week and 0.8 milligrams per kilogram every 2 weeks. And so these responses were not only seen at the 73-74% in the overall cohort, but they were also maintained in triple-class refractory, pentadrug refractory, ISS3, high-risk disease, lines of therapy. The only subgroup that probably needs more attention, which is true of all T-cell redirections, is extramedullary disease, which is about 50% of patients. So, which is even there, the response rate was 50%. So this is really encouraging data. And I would also mention that there's a 3rd cohort of patients who had prior T-cell redirection therapy, meaning they had prior CAR-Ts and bispecifics, which is the new unmet need in myeloma. And even in those patients, we saw an encouraging response rate of 62+%. And so the efficacy results are really encouraging. The safety profile of this drug is also important to talk about because the grade 3-4 toxicities were relatively uncommon. They were primarily hematologic, and even those were in less than 1/3 of the patients. And those cytopenias typically happened early on in the treatment. That's important because it lends itself well to other combination strategies where you might see cytopenias with other drugs. Secondly, the infection profile is something that's very unique about this agent, and I would say distinguishes it from other drugs. First, the rates of grade 3-4 infections, which with bispecifics have been as high as 45%, although admittedly with perhaps longer follow-up. Here, the rates of grade 3-4 infections were 10 to 15%. Second, even though this agent has also been studied in the era of COVID, this study, there were 2 COVID deaths and there were 0 COVID deaths in the phase 1 study. So now we're talking about a combined data set of over 500 patients in which there's a very little COVID signal. That's also supported by the fact that in our lab at Mount Sinai, when we check COVID antibodies in response to vaccines on these patients, they have excellent responses. And finally, the rates of IVIG use in this study was only about 10%, which all of these 3 parameters compare favorably with some of the other bispecifics being studied. But there are some unique on-target off-tumor effects, and those are Skin, we do see some rashes, which are typically managed with oral and topical steroids. Nail changes, and finally dysgeusia, or dry mouth, loss of taste. That one's the hardest to manage. We haven't found the magic bullet yet, but we've of course done supportive care with hydrating agents, lozenges. But what we have found has been helpful is the decreasing the dose intensity, either the dose or the schedule of the drug. And what's evidenced, what supports this manageability is that only about 5% of patients came off for adverse events. So the majority of patients are basically benefiting from this drug, and really with a minimal infectious profile. And so I think it's a really exciting new option for patients. So what are the next steps? The BLA was just submitted this week. We hope, because of the breakthrough designation it received, that it'll get an accelerated approval strategy, and we should get an evaluation of the BLA in maybe 6 months. And then in the interim, there's a confirmatory randomized phase 3 study combining this drug with other agents in comparison to a control arm. Also, there are phase 1 studies combining this agent with other backbone drugs in myeloma, but also the sister bispecific, if you will, talquetamab, and also checkpoint inhibitors. So a lot of exciting studies down the road. And I think it'll be interesting to see not only this drug get approved, but where it'll end up in terms of hopefully in earlier lines of therapy so that we can really help the most number of patients.